It's a pleasure to be here. It's a pleasure to be talking about this topic that I feel very passionate about and that I feel sometimes gets neglected in the work that we do and the services that we provide, that we don't always consider some of the cultural factors that might be affecting the patients that we work with. So today I'm going to try to give you an overview of some of the most pressing mental health issues amongst Latino populations. I'm going to try to review some of the disparities that are out there as well. We all know that there's some significant concerns about ethnic minorities, and I'm going to speak specifically about Latinos not getting the services that they need or not staying in the services nearly long enough to benefit from what we have to offer. And then I'm going to review what's the state of the evidence, what's our best evidence that we have to treat Latinos with different mental health problems. And I'll end with a little bit discussing some possible future directions for the field. So with that, I'm talking about Latinos and Hispanics. I have multiple computers up here. Here we go. I'm talking about Latinos and Hispanics. We do realize that this is a very diverse group coming from multiple countries, more than 20 countries who are of Latino and Hispanic origin who are now living in the United States. So I'm going back and forth between Latino and Hispanic. I'm not certain how accurate this is. Keep calm, nobody cares. I think that's really between you and your patient to figure out if they really care about whether or not you're going to call them Hispanic or Latino. Some people, I know, some parents feel very strongly about being called Latino and not Hispanic, or the other way around. If we look at some of the Pew Census data, it looks like most parents, if you ask them what term they use amongst Latinos, most parents are going to say their country of origin. I'm Mexican, or most kids too, actually. I'm Mexican, I'm Mexican-American, I'm Cuban, I'm Argentinian, I'm Salvadoran. 50% will default to their family's country of origin. The other 25% or so will refer to themselves as Hispanic or Latino. The other 20% or so will call themselves American. So there's variability. That variability is probably, well, there's different factors that affect the variability. There's probably some generational differences, which I'm not necessarily presenting, but right on this slide, but from first generation, it tends to be they're more focused on country of origin as a label, so I'm Mexican. As you go to second and third generation, they're more often calling themselves American or Mexican-American. So there's that generational difference. I thought there might be more striking differences in region, but that's not necessarily the case unless we look at Texas, where most people in Texas are going to go by the term Hispanic and not Latino. But in the other states where there's a large proportion of Latinos, it's rather even as far as the majority are still 30-ish% are still going by the term Hispanic, 20% are going by Latino, and the other half are saying you could call me either Hispanic or Latino. It doesn't really matter. So with reference to nobody cares, about half of people don't really have a strong preference between whether or not you're going to call them Latino versus Hispanic, okay? So population-wise, we see that our largest Latino groups are Mexican, followed by Puerto Ricans, and then Cubans. The groups that are experiencing the greatest population growth right now are actually Guatemalans and Salvadorans. So I don't know if you've seen in Florida, if you've seen more individuals from Central America coming into your practice. That is the trend at this point. Okay. We've seen slides like this before, likely, or in some other news or media, that the growth of the Hispanic population continues to double, perhaps. And we're going to see that continuing growth through the next few decades. We don't anticipate any decrease in the growth of the Hispanic population. So it is a demographic that we should have on our radar, that we likely will be working with, if you're not already working with individuals who identify as Hispanic or Latino. Likely in Florida and some of the other states, California, New York, Texas, there's a good chance that you are going to encounter a large portion of Latinos in your practice, perhaps. So I already told you a little bit about the overview. I'm going to go straight into, actually I'm going to do a disclaimer because I want to also acknowledge, as I was saying before, we are a diverse group. We come in many shades, shapes, colors, creeds, ancestries. We have different countries of origin. We have different migration histories, which make a difference. And some of our risk factors and our mental health outcomes. There's differences in skin color, and believe it or not, there's still some research being done to suggest that skin color is associated with less favorable mental health outcomes, and this is recent data suggesting this. So we come with different experiences of discrimination, documentation status, SES levels, social adversity. So even though there's commonalities that you'll see on one side, such as language and shared cultural stressors and perhaps some shared cultural values, values of collectivism and familism, perhaps some shared religious values and practices. Even though we have many similarities, we also have many differences that we need to consider when we're in practice working with Latinos. So I'm going to start just by giving a bit of an overview of what prevalence rates of some of the disorders look like. What are some of the ethnic differences? Where do we see the most striking differences as far as Latinos having higher rates of specific psychological problems compared to non-Latino white populations? There's not a whole lot of epidemiological data for us to base this on, for us to look at these ethnic differences. Most of our big survey studies have not included large enough groups of Latinos to really, to replicate the findings or to say that the findings are very strong. The studies that have looked at differences typically find more similarities than differences in rates of psychological disorders. But there are a few disorders, a few problems that we seem to find consistent differences. And these are in the mood disorders, so depression, anxiety, as well as suicidality. We tend to find somewhat consistent differences there, with Latinos having higher rates of these problems, Latino kids having higher rates of these problems than other groups. In addition, there's some data to suggest, not as much, but some data to suggest that there's also higher rates of substance use problems as well as aggressive behaviors in Latinas and Latinos compared to some other groups, okay? And I'm just going to show you some of the slides some of the data to support that. Here we have a few different studies, one being a big meta-analysis, 301 samples of kids and adolescents, 8 to 16 years old, totaling a sample of about 60 participants. 60,000 participants. And here we see that Latino youth have significantly higher rates of depression compared to white and African American youth. Second, in a longitudinal study across multiple waves of data, we see consistently that they're presenting with higher rates of depression. And we might think, oh, of course, this makes sense. This is a function of poverty. They experience more socioeconomic adversity. That's not the case. this finding persists even when we control for income and other sociodemographic features, okay? Most concerning, or as concerning in some ways, over the past decade, I think these findings first came out in 2005. I just looked at the most recent updates from 2015, where we're still seeing Latina teens, adolescent female Latinas, having higher rates of suicidality. This is from the Youth Risk Behavior Surveillance Survey, in which every year they survey kids. They ask them multiple questions about risk behaviors, such as sexual risk behaviors, drinking, smoking, as well as things like suicide, carrying a gun, those types of risky behaviors. They ask 5 questions about suicide. And like I said, in the most recent 2015 survey, we're continuing to see those elevated rates among our Hispanic female teens, having higher rates than Hispanic males, having higher rates, significantly higher rates than Hispanic males across these 5 questions, significantly higher rates than Black females across these 5 questions, as well as significantly higher rates than white females across most of these, not all of these parameters. Unfortunately, it seems like for white females, there's been a bit of an increase in some of the suicidal behaviors, whereas before, there were significant differences on all the parameters between Hispanic females and white females. Now that's not the case. Now it's only some of them, but that's because suicidal behavior in white females has increased a bit as well, okay? So it's certainly something that we think a lot about in the research that I do, and the practice that I do, and the parents and families that I see, these concerns about suicide and what's driving these increased rates of depression, as well as the increased rates of suicide or suicidal behaviors, I should say, in this population. Okay. In addition to depression and suicide, we also see elevated rates of anxiety symptoms, not necessarily, we don't see big differences in rates of actual anxiety disorders, technically not differences in social anxiety disorder or separation anxiety disorder as a DSM-defined disorder, but we do see differences when you look at symptom levels, with Latino youth reporting more separation anxiety symptoms, more worry symptoms, as well as more somatic symptoms, some more physical complaints that seem to go with their anxious feelings. We also see higher rates of PTSD in this population, but this seems to be, compared to non-Latino whites, but this seems to be a function of Latinos are often exposed to more traumatic stressors and live in poor neighborhoods and urban neighborhoods more often than non-Latino whites do. Okay, so there's some different risk factors that Latinos have that we need to be thinking about. And lastly, like I said, with externalizing disorders, the findings haven't been as consistent. They're a bit of a mixed bag, where we see in some studies Latinos and Native American youth having the highest rates of alcohol and drug use, that Latina adolescent females have highest rates of aggression compared to both white and Black adolescent females. For males, the pattern's different. It's actually Black adolescent males who have higher rates compared to the other groups. But at the same time, we see Latinos presenting with lower rates of ADHD than other groups. So we could think, there's likely different reasons that may explain the higher rates of aggression, the higher rates of suicidal behaviors. I'm going to present a slide. My next slide is going to kind of address some of this. As far as the lower rates of ADHD, some people offer it might be a measurement issue. Some people offer that There might be different expectations of what child behavior should look like in Latino families, so perhaps they're less likely to see things as a problem, to see things as impairing, because it's just typical childlike behavior. So that might be part of why we're seeing lower rates of ADHD. Some people, how many people know about the immigrant paradox, the Hispanic paradox? Has anybody heard? I see one hand, that's okay. A couple hands, a few hands, great. So the Hispanic or immigration paradox is this finding that's come out of the literature where it seems, for whatever reason, some of the data has suggested that immigrants have better mental health outcomes, better mental health functioning than people who have been in the US longer, okay? So immigrants from Mexico have better mental health outcomes than US-born Mexicans. This is termed a paradox because you would think that immigrants would have more stress, that the process of coming to a new country would be very difficult. There might be a host of other problems that come with being an immigrant that would produce worse mental health outcomes. So the thought has been that what's happening is that the more time you spend in the US, the more you see an erosion of the cultural values that could have been protective. So as an immigrant, you have certain cultural values of collectivism and harmony and familism and religion, and those things might protect from poor mental health functioning. And that's why, over time, as those values erode, you're going to see more mental health problems. So this has been the explanation of this immigrant paradox. The more we study it, though, the more we're finding holes in this immigrant paradox. It doesn't seem to be consistent across groups. Some of the largest, most well-done studies, National Latino and Asian American survey done by MCKAY, Alegria, and others at Cambridge, they found that this finding was specific to Mexicans, that it didn't hold for other Latino groups. It didn't hold for Cubans. It didn't hold for Puerto Ricans, that the protective effect of immigrant status only seemed to be true for Mexicans and only for certain types of problems, only for anxiety, only for mood disorders, only for substance abuse. So it wasn't across the board. It was specific to certain groups. And then when we look at some of the adolescent data in the risk for certain disorders in our immigrant adolescents, it's not supporting this immigrant paradox. We find lots of adolescent immigrants who present with higher rates of substance use, higher rates of depression, higher rates of social isolation, higher rates of aggression than their subsequent generations of Latino or US-born Latinos. So it seems to be the case that, yes, there might be some support for adults with this immigrant paradox, particularly Mexicans, but that doesn't seem to be holding when we look at immigrant youth and Latino youth, this idea that immigrant status is protective, okay? So it's a lot more complicated than just looking at generation level and saying you're first generation, second generation, or you're immigrant, not immigrant. I could expect this from you. I could expect that from you. It's a lot more complicated. It's not about this kind of dichotomous variable, are you this or that? It seems to be more connected to what you experience as part of the immigration process. How difficult that adaptation process is for you, how receptive the host country is, how smooth you find the transition, how quickly you're able to adapt and adopt and integrate practices. If you're not able to do that, if it's not a smooth process, then that's usually been termed as something we call acculturative stress. Certainly, if you're not welcome, if you feel like you're being treated unfairly, those are not just being discriminated against. It doesn't have to be you experience actual discrimination. It's just the perception of discrimination that can lead to poorer outcomes. And it's these two variables, acculturative stress and perceived discrimination, which we see continually in the youth literature with Latinos as being linked to poorer outcomes, being linked to suicidality, being linked to depression, being linked to anxiety and substance use. Okay, so not acculturation itself, but what happens in the process, okay? Or how difficult that process is. This is a complicated slide with lots of boxes. It's a nice integrative model to look at if you're really interested in thinking about acculturation and how acculturation really affects parents and kids and how it affects the functioning of the environment. I think this demonstrates, most importantly, that these variables here, such as discrimination, acculturative stress, from both the child perspective and the parent perspective, are leading to poorer mental health outcomes. And I think what else is interesting here, which we see in the literature, is that the differences between parent and child in acculturation leads to some intercultural, intergenerational conflict, which creates some family distress, some family dysfunction, and that also we see leading or being a risk factor for things like suicidality, depression, and anxiety in Latinas, but particularly Latina teens. So it seems like the studies have suggested that these intergenerational differences drive family conflict, and given the valence, given the importance of family amongst many Latinos, that those family conflicts are very important, or that type of distress is very important and just very disruptive, very dysregulating, let's say, to the Latina adolescent, which leads to increased risk for behaviors like suicidal behaviors or depressive symptoms. Okay, so that gives you an overview of what are some of the most pressing mental health issues amongst Latino youth, as well as what are some of the risk factors in Latino youth. So we know they're prevalent, we know they're as prevalent, and in some cases these problems are more prevalent than what we see in non-Latino white youth. But despite that prevalence, we continue to see many types of disparities present when we're looking at differences with Latino youth and non-Latino white youth. We see differences in service seeking, with Latino youth using significantly fewer mental health services than other groups. They're less likely to participate in clinical trials, which drive the evidence base to determine for whom these interventions are effective. There's a bullet there looking at the OCD trials. Now these are OCD trials in both adults as well as kids, but in 21 trials for OCD, which equals about 2,000 kids, about 90% of those, I'm sorry, not just kids, kids and adults, about 90% of those participants were Caucasian. About 1% were white, 1% were Latino, 1% were African American, 1% were Asian. So, they're not participating in many of the trials that drive the evidence base for us to know what works. Okay, that's unfortunate. That's a disparity. It also means they're not likely receiving the same quality of care of services that other groups might be receiving. They're more likely to drop out of services. They don't engage as well in services. They're less likely to be detected, so less likely to be diagnosed with depression, and they're less likely to be prescribed medications by their doctors than other groups. And granted, it could also be that from the data we know that Latino families tend to be less accepting of medications as well, so they may not be asking for the medications as much, or they may tell the doctor from the get-go, I don't want medication, that's not an option for us. But whatever it might be, there are significant differences, significant disparities there. Okay. So lots of reasons for these disparities. We could call them barriers that Latino youth are experiencing as they're trying to get services or in seeking services. There's a host of barriers that have been identified in the research literature, things involving what we call more perceptions of needs. So do they consider the problem to be serious enough? Is it causing enough of a burden for the family? Some demographic factors, characteristics that may be acting as barriers to getting services, like the Latino families may more likely be single, and being a single parent may act as a barrier. There may be lack of family cohesion, which may make it more difficult to get services, poverty, the other beliefs, stigma, previous negative experience with mental health services, language proficiency, not connecting well with your provider, not feeling there's a good therapeutic alliance there, as well as a host of logistic barriers, transportation, childcare, cost, mental health literacy, not knowing where to go, not knowing what services are all about. So a lot of barriers that may be getting in the way and may be increasing or leading to some of these disparities. Just a little bit of extra, I want to make a couple notes about the beliefs. So certain cultural related beliefs that also may be acting as barriers. In the literature, we see that Latinos are less likely to recognize need, and they're more likely to minimize impairment. Okay, so even though the symptoms might be the same across group, they may not prioritize mental health as being what's most salient in their life, and they often discount how impairing it is. It's not so bad, it'll go away, it'll get better, etc. There's certain beliefs about discipline which we've seen that have been shown to be linked to premature dropout. Beliefs that by particularly Latina moms that resemble this idea, I'm not doing a good enough job. It's my fault if my kid's acting out. They don't need therapy. This is me being a parent, and if I would step it up a bit more and being a better parent, be a better disciplinarian, engage in more discipline, then that's going to fix my kid. It's not going to be therapy that fixes my kid. I need to change myself, and that's going to make the difference. So there's that belief that we've seen has predicted premature dropout, as well as the belief that among lots of Latino parents, they believe their kids' problems are transient, situational, they're going to go away, it's not going to stick around, it has to do with that teacher, it has to do with that kid, it's going to get better, okay? In some ways that could be good, but in the presence of a real mental health problem, kind of minimizing the importance or seeing it as somewhat situational and temporary, that's not going to allow parents to get kids the help that they need. Okay? So sometimes these beliefs can get in the way as well. So in the context of there's increased mental health problems, lots of disparities, what can we do? What do we do as providers? What do we do as clinical researchers? How can we advance and improve the quality of care of this population? I'm going to give you a couple ways. I think there's lots of ways we can do it. I'm just going to present a couple ways. I think we need to really think seriously about the barriers that are being experienced by Latino families and Latino kids, as well as how we can improve engagement of these families and kids in the therapy process. How do we get them to the door? And once they're at the door, how do we get them to stay in therapy? And then second, above and beyond that, how do we get them how do we make certain that they are getting services that work? Effective services, evidence-based services, okay, that work for them. Okay. So there's all kinds of renditions of if you build it, they will come from the Field of Dreams. This is my favorite one. It's not necessarily true if you build it that they will come. We've seen that over and over again, that services can be available, that there might be some outreach, but that doesn't guarantee that they're going to make it to the first session or that they're going to stay in therapy. Mary McKay and others, who I think she spoke at this conference a few years ago, I think she has an excellent body of work demonstrating how effective the use of engagement strategies can be to get to address barriers that urban families, Latino families, African American families may be experiencing, strategies to address those barriers and to increase the likelihood that your families are actually going to come to therapy and stay in therapy. Dr. McKay's work presents these 4 or 5 somewhat basic strategies and recommends that you do these things either at the first telephone intake or at the first in-person visit, that you try to be preemptive and help people consider what might get in the way of them staying in treatment or coming back for services, okay, or making it to services in the first place. Okay, so the first thing up there is to provide education about the therapy process. We know that there are, particularly in low-income areas or some urban areas, there's going to be less mental health literacy amongst Latinos. They likely will not know what therapy is all about, that it may be a big question mark for them. It may be somewhat of a mystery for them, and your challenge as a therapist is to demystify that process for them, to explain to them what's going to happen, what to expect, what their role is going to be. Second thing is to increase parental investment and parents' belief that they can make a difference, that they could have some kind of impact on what's going to happen for their child in the therapy process, and that with their help and support, that there's likely to be better outcomes for their child. Remember, go back to those beliefs. Some Latina parents or some Latina moms have this belief that it was my fault, I did something wrong, I'm to blame, and they're not in this mode of thinking, I'm also part of the answer. I could make a difference, I could produce change as well. So part of our job is to help them understand that they still have an important role in producing change that could help their child. Number 3 is to talk about things like stigma up front. Ask parents how they feel about mental health services, not only how they feel about it, but how others in their family might feel about it, how others in their community might feel about getting mental health services. Because I guarantee many parents are going home and talking to family members who may not have such kind things to say about mental health services and going to see a provider. And it's nice if you have had that discussion with parents ahead of time to give them some way to respond to those family members who say therapy doesn't work, therapy is for kids who are crazy, our kids aren't crazy, why are you taking them there, they don't need it. It's nice if you have that discussion with parents ahead of time, okay? Next, to address perceptions of, this is more so to address if they've had previous negative experiences with mental health clinics where they feel they've been treated unfairly or where they feel they've been discriminated against. It's nice to understand, what happened in the past and to help them reframe that or help them understand how this experience should be different than what they experienced before. Okay, if they felt invalidated or dismissed, or that the therapist didn't understand them, or that there was language problems, some discussion as to how you're going to be proactive to make certain that that's not going to happen again. And then lastly, to problem solve barriers. This may seem, sometimes it may seem more like case management, but I would argue that if you're not doing a little bit of this or not connecting to people, the services, or not connecting your patients to people who could provide these services, you're not going to see Latinos back in your office if they're experiencing certain obstacles. Okay, there's a study that suggests that relative to, and it's very consistent with Maslow's hierarchy of needs, relative to other issues, relative to education, relative to, do I have a safe home, do I have employment? Mental health is going to be at the bottom of the list of priorities in Latino families. Okay, they're worried about some of these other things first and foremost. So when you're problem-solving obstacles, you're helping them to get connected to, yes, is there somebody who could help you think about, where to apply for food stamps, or how to get your kid to see the counselor that they need to see at school. You may also problem solve some more practical barriers, just as simple as, how are they going to get to the session? Who's going to bring them? Are they coming by themselves? What time are they going to come? Can we provide any kind of after hours care? What are they going to use for daycare? Those types of things. Being preemptive and thinking about what might get in this patient's, in this client's way of our therapy process, of our therapy program. Okay. So Mary has Dr. MCKAY has lots of work in addition to what I'm presenting here, showing that her engagement strategies work. This is Dr. MCKAY's application of the engagement strategies in the context of multifamily group therapy. And you'll see this is the trajectory of what attendance typically looks like when you're not applying these engagement strategies. And this is what attendance looks like when you are applying the engagement strategy. So this is over, I think, 16 sessions or so. So you're getting some promising effects on attendance throughout the treatment. Okay. So it's certainly, if you want to have a patient in the office, if you want to have a family in the office there to work with you, it might be worth it to try some of these engagement strategies if you're noticing there's difficulty with getting your client to session. Okay. But as I mentioned before, engagement's not enough. We want people to show up. We want people to stay in therapy, but if the therapy we're providing isn't quality therapy, then we're probably not doing much for that family, for that child. So whenever possible, consistent with all our interests here at the conference, wherever possible, we want to be providing evidence-based practices for Latino families and kids. Okay? So this should look familiar to many people. There's been a certain system that's been developed to determine what is considered evidence-based practice and what the level of evidence is for different practices. The best level of evidence is something that's well established, followed by probably efficacious, followed by possibly efficacious. Okay, so there's different levels, and whether or not they meet that classification depends on how many studies, how many trials are there out there that say it's a good intervention, as well as were those trials done with good methodological rigor? Did they have a manual? Did they have randomization? Did they have independent evaluators? So was that combination of rigor there, as well as are there a number of studies saying that the treatment works for that group? Okay. The good news is, and if you go to Division 53, Effective Child Therapy, you will see a couple menus, screens that you could click on, in which you could go to EBTs or EBPs for specific disorders. You click on the disorder, anxiety, anorexia nervosa. It has all the childhood disorders. And it tells you what the level of evidence is. Is it well established? And it'll tell you which studies. It's a great resource, I think. Very helpful. And we know that there are many well-established treatments out there right now for kids who have various emotional and behavioral problems. Okay. The problem is, so we don't know if those findings are generalizable to our ethnic minority youth, as specifically to our Latino youth. Most, as I mentioned before, as you saw in a slide before, many of our studies that provided the evidence have mostly been done with non-Latino white kids. So it's hard to know in that context, or the studies that do exist with ethnic minorities often have very small samples of ethnic minorities, so you're not able to do the type of analyses to show that this treatment works as equally well across groups. So there's a problem with the external validity of our interventions when we're thinking, can we apply this intervention that was, the evidence was based on Latino whites, can those findings apply to ethnic minority youth? So in 2008, Stan Huey and Anthony Polo did a meta-analysis where they gathered all the studies out there that were looking at the evidence for the different interventions that we have. And they applied, in addition to the CHAMBLESS criteria that I presented on the previous slide, they applied some additional parameters to try to get at, in addition to being evidence-based, are they evidence-based for ethnic minorities? And their additional parameters are in the study. They wanted to see there was a large portion of the patients who actually were ethnic minorities, so 75% of the participants would have been ethnic minorities as defined by one of their parameters, or they were able to conduct separate analyses with specific ethnic minority groups to see, did the minorities who received the treatment, did they do better than those who received the control? So they had to have a large enough group to do that. Or they looked at the effect of moderation, and they said, is there an interaction effect where, you know, minorities are not doing as well as the other groups when they receive the intervention, okay? So they were looking for these additional parameters when they were seeing if these interventions are useful for ethnic minority groups. So in 2008, there was the original meta-analysis. Recently, I've been working with a colleague, Armando Pina, where we're revisiting that evidence, we're updating the evidence to try to see what the state of the literature is currently, as of 2017. So in 2008, as far as what was well established for Latinos, based on those additional parameters, there was no intervention for anxiety or depression or conduct problems, nothing for trauma, nothing for substance abuse. When we looked at it in 2017, what we found was nothing available for anxiety, nothing available for depression, nothing available for conduct, nothing for trauma, and nothing for substance abuse. And I say nothing, meaning nothing that meets definition of well-established, okay? So we don't have treatments with the best evidence possible available for Latino minority youth just yet, okay? That's the glass half full, okay? The glass half empty is we do have some interventions that are probably efficacious. We do have some interventions that meet the standards of being possibly efficacious. So it's not all bad news, far from it. So for depression, CBT, individual and group format is meeting standard for probably efficacious. For anxiety, group CBT, as well as individual CBT plus parent involvement. That meets the threshold as well for anxiety as being a good treatment to use for Latinos that has good evidence behind it. For ADHD from the MTA study, the combined behavioral treatment with medication, that seems to be a useful intervention. And for conduct problems, there's a host of different interventions related to some of the family therapy work that we've been talking about here at the conference, providing some effective, probably efficacious interventions for conduct problems, problem-solving interventions, PCIT that actually has a cultural adaptation to it that's been shown to be effective and give us good evidence as well as Mary McKay's multiple family group therapy has also some good evidence to it. Possibly efficacious, so again, kind of the third tier of our levels of evidence. Possibly efficacious is IPT. We have IPT for adolescents as being one of the indicated treatments for depression, as well as some school-based CBT, group-based CBT, and for PTSD and trauma symptoms, we have the CBITS program that has been shown to be possibly efficacious for Latino youth, okay? So again, there are some interventions. It's not like we don't have any evidence base to go upon, to go to when we're trying to see what does the literature say, what should I use next. There are some things, it's not necessarily some things with the best evidence, but some things with good evidence, okay? One thing you might be asking is, were these interventions that are shown to have good evidence, were these cultural adaptations? Was this evidence-based practice, was this CBT with a cultural adaptation, or was this just CBT as usual? Okay? And the answer is it was a bit mixed when we looked at all those studies. We had some interventions that didn't change much about the evidence-based practice, and we had other interventions that did, that attempted to provide a culturally responsive adaptation to the intervention. And here's a list of some of the different things that the interventions that I have on our list were doing to make the treatment more appropriate for Latinos. So they were doing things in brief strategic family therapy, like addressing the intergenerational cultural conflict that I talked about that can lead to poorer outcomes when there's those acculturation differences that are leading to family conflict. Brief family therapy was trying to address those intergenerational conflicts as effectively as possible by bringing the two cultures together, or by bringing those differences together and helping the kids to see this more so as, you know, this isn't a matter of mom and child not getting along. This is a matter of our cultural differences are making it harder for us to get along, are making it harder for us to match, to align, to feel connected. So it's more so a matter of culture differences than us as mother and child being different. Our CBITS study, it was somewhat vague as far as what they did to make it appropriate for multicultural groups. Our CBT for anxiety, they did cultural sensitivity training, as well as they taught their therapists how to work with different conceptualizations of mental health problems, different frameworks they may have for defining what anxiety is, the different roles of parenting and anxiety. There's a finding out there that, usually we think of over-controlling parenting as increasing anxiety in kids. In Latinos, we don't see that same relationship. Over-controlling, overprotective parenting is associated with less anxiety, and the idea is that there's a different conceptualization of what that parenting means. Over-controlling parenting within Latino culture could be a sign of warmth, love, and obligation, family obligation, very consistent with the family value. So you don't necessarily have those same patterns across groups. And that's what something like this intervention was attending to. And then IPT, or CBT for depression, the IPT and CBT modifications, they use the ecological validity model, which Dr. BERNAL was presenting on a couple days ago. I'll show a slide on that next. And PCIT is also an interesting one because they use more of a prescriptive tailoring approach, which I'll talk about in one of my next slides. So this is Dr. BERNAL's slide. When you're using this ecological validity model and you're making adaptations to your intervention, you're attending to these different elements and making changes to the intervention. You're letting these elements guide your changes to the intervention. So you're matching language, persons, you might be matching therapist ethnicity or language proficiency, metaphors. You might be using certain examples, sayings, dichos, proverbs to make the intervention more attractive to the family. Content, you might be including certain values throughout. You might be infusing certain values throughout the intervention, such as familismo or respeto. Those might become important content to include in the treatment. And we'll go through in context. Maybe you're including like larger sociocultural factors that are affecting the child's depression, such as discrimination or political climate or socioeconomic adversity or things like that, okay? So this is a more extensive adaptation that's being done for that CBT for depression intervention, okay? It includes a lot more elements. It's a bit more systematic than some of our other treatments. As opposed to Kristen McCabe's adapted version of PCIT called Ghana, she uses more of a tailoring approach. And by tailoring, what she does is in the beginning, in the initial assessment phase, she administers some questionnaires to ask about cultural values, to see how important cultural values are for the family, for the Latino family. She also asks about questions about practices that are part of PCIT that might be influenced by cultural values. She asks about those things from the get-go. So things like, how do you feel about strict discipline? How do you feel about praising your kid? What kind of rewards do you like to use for your kids? In this literature, we found that many Latino families do not like tangible rewards. They don't like monetary rewards. They don't like giving toys and money and those types of things, that they prefer social praise. They prefer social rewards. So in this work, they're trying to get at that. They're trying to understand what is important for this family. We realize not all families are going to be the same. What is important for this family culturally that we're going to have to tailor and adjust? Okay, so it's more of a tailoring prescriptive approach. Okay, so some of the interventions, like I said, had adaptations. There was a range of adaptations that were made. Some of the interventions didn't have adaptations. So a logical next question is for myself and many people who are very interested in this type of research, does it matter to do an adaptation? We spend a lot of time, we spend careers doing adaptations, trying to figure out the best match, something that works the best and feels the best to ethnic minority families. How much do those adaptations matter? Do they make a big difference? And in this meta-analysis, now granted it was a small number of studies, in this meta-analysis, when they examined adapted interventions, adapted EBPs, let's say, versus non-adapted EBPs, what they found was, I'm going to do the glass half full because I'm trying to be optimistic. What they found was the adapted interventions were effective. They produced medium effect sizes with Latino families, with ethnic minority families. But what they also found was that the non-adapted interventions produce similar effect sizes, the same effect sizes, okay? So in essence, the adapted interventions were not outperforming the non-adapted interventions, but they were as good as the non-adapted interventions, okay? So, you could interpret it in different ways. I think it's left some of us scratching our head, trying to wonder, okay, what do we do next? Do we stay the course? Which way do we go? Do we just try to work on getting, not adapting treatments and just getting more people to participate in these efficacy trials? Or is there some other way? Do we continue to do our adaptations? I've taken the a common response that maybe psychologists give. I'm doing both, or I'm thinking of it in both ways, that I'd like to, what we're doing is we're staying the course a bit. We're not giving up on adaptations, or we're not saying that adaptations don't have anything to offer. But I think in addition to that, we're also trying to learn from what's happening in the literature and to advance our research, our clinical research, so that we could do things differently and get some more valuable data about what makes adaptations valuable. And I know I'm running out of time, so I'll just do a couple more slides here, and I think I'm done. So should we continue? This is some of the reasoning, at least what helps me sleep at night when I think, should we continue with these adaptations, and is it a useful effort to continue to do this? What's been done, it's a small body of literature. There's not a lot of studies. Many of the studies that we've included in these meta-analyses don't really have good sample sizes. So I think there's more work to be done to look at additional studies and larger studies where we're testing these adaptations. Where the funding is going to come from, I'm not certain, but I still think there's work that needs to be done. Despite having similar outcomes, one thing that we have noticed from our adaptations is that clients prefer the adaptations. They like it better. And that could translate into better engagement and better attendance if they're saying, yeah, this fits me. I like it, it feels good, okay? So I think there's something to be said for that outcome as well. In the adult literature, we do have data that adaptations are effective and that do produce better outcomes for some Latino groups, particularly those who are less acculturated and those who are immigrant, mostly Spanish-speaking populations. These adaptations, at least in adults, have been more effective than our standard EBPs. So I think there's justification to stay the course. I also think there's justification to veer off course a bit. And this is a bit of my future directions. I think it's future directions more so from a research perspective as far as what I think the field, what we need to be doing. First and foremost, obvious enough, we need better representation of ethnicity in our efficacy trials. We need to consistently look at ethnicity as a moderator in our efficacy trials to see if the intervention is performing the same across groups. I would argue also that we want to look at other things besides ethnicity as a moderator, such as immigrant status, Spanish-speaking or not Spanish-speaking, to learn more. I think we need to continue to examine risk and protective factors for Latino youth. Things like, how exactly and how big is the impact of discrimination on mental health outcomes? What is the impact of having a positive identity? There's some research to suggest a positive ethnic identity can buffer the impact of discrimination and acculturative stress. So should we be including some of these risk factors as well as protective factors in our interventions? We probably need more data looking at these questions in order to bring, to translate this basic research into our studies, into our interventions. I think we do need to do a better job of describing our adaptations. I think that's very inclusive of, when we're in practice, when we're working in the community, what adaptations are actually going on. Let's monitor how is the intervention being changed. Some of the data is suggesting that if you add to the intervention, if you keep the intervention pretty much the same, but you're just adding components to it, or you're adding some content to it, that's going to lead to more favorable outcomes than if you're deleting parts of the intervention, than if you're dropping out skills, or if you're totally revising the way the skill is supposed to be delivered. That's not going to lead to good fidelity, and that's not going to lead to better outcomes. But if you're just adding content, that seems to be more preferable if you feel that there's a reason for cultural mismatch. So I think we have to be describing those adaptations better And we need to really be thinking about, in our existing interventions, what are the active ingredients, what are the core mechanisms, is it family functioning, is it family cohesion, is it changing thoughts, and if so, are the adaptations we're making, are they acting on those mechanisms? Are they affecting those mechanisms? Maybe we don't need to make so many adaptations. Maybe we need to be a lot more selective and just make adaptations that are really linked to the core mechanisms that activate our treatments. Yep, that's it. Thank you very much. I don't know if we have time, do we? Okay, yeah. Hi.
Thank you so much for your talk. This is an area that is very near and dear to my heart. I wanted to talk for a minute about the issues of generalizability and even the generalizability of these culturally adapted programs. Just briefly, a little history. I did my graduate training at Arizona State with Nancy Gonzalez, and was one of the people who was first involved in developing the pilot intervention of bridges. So that dates me quite a bit. And then spent a lot of time there and at University of Illinois at Chicago doing this kind of work from the perspective of these sort of evidence-based treatments, randomized controlled trials, and spent a good 10 years learning how to work with low-income Latino youth in very great places, both research-wise and clinically, wonderful practicum experiences and internship experiences. And then I moved to South Florida and thought, I am so ready to work with low-income Latino families. And I had to call Nancy back and say, Nancy, I thought as long as I learned how to work with low-income Latinos, and not relied solely on research conducted with middle-class European American families, that I was going to feel well prepared to do this work. And I'm calling to tell you that I do not feel well prepared without making adaptations, cultural adaptations, again, to work with low-income Latino families in the South Florida area. The risk and protective factors, some are shared, as I'm sure you can imagine, and some are really quite different. Beginning with that our low-income families in South Florida were not necessarily low-income or had low education levels in their home countries. More recent immigrants, where some of the acculturative struggles were not that kids were becoming Americanized. It's hard to become Americanized, actually, in South Florida. In fact, we had Argentinian parents very upset that their children were becoming Cubanized. But that, well, no, that's very true. It is a thing. It is a thing. It wasn't about that. It was resentment about why did we leave our country. You put money ahead of family and friends. I mean, separations and reunions over the process of immigration, the risk and protective factors are completely different. And in the meantime, as you're showing these slides of 2008 to 2017, every clinician in this room and researchers, I'm a professor here in the area, we can't wait for all of this.
17 years is what it takes from start to finish to get these EBPs out.
And in the meantime, how many of you have clients that you're serving right now, today, right, who we need effective services? And so I'm really just, listen, I believe in the models that I was trained in, I do. But I also see where those models are a big part of the problem in research to practice gaps. This time lag, the fact that we have to serve our clients when they show up, not when we're ready for them. You know, this has been a real struggle, and there are some things that my team and I have done to try to sort of reconcile these things, and some interventions that we've sort of done, and trying to do much more small sample research and much more sort of combination of qualitative and quantitative work. But in the meantime, I think those models, they're part of the problem as well as part of the solution. And I don't know how to say that. I say it with all the best of intentions. And a lot of admiration for the work that many, many people are doing all over this country, but also having run face first into the real challenges. And so I guess it's not so much a question as a comment, but how do we go back and look at what we're doing and try to make it much more responsive in real time to the needs of clinicians and these families and kids who are struggling today.
It's a wonderful comment, and it's well taken. I understand what you're saying. My hope is we're going to try to start moving towards more of a personalized approach, more of a prescriptive tailoring approach that relies on assessment in the beginning, in that initial phase, to understand what the stressors, cultural stressors might be for that person. And that's, that's all part of conceptualization. That's all part of understanding your client. And then using what you learned from that cultural assessment, using what you learned to tailor the intervention to be appropriate, and perhaps not to change the intervention, but to add on pieces that you think would be particularly relevant, or to emphasize certain pieces or certain themes a bit more because you know that discrimination has been relevant, or that loss has been relevant, or that familism and family support is relevant. But learning that from this initial assessment process, conceptualization process, and really letting that drive your tailoring and the way you deliver the intervention.
That is what we're trying to do, so I'd love to chat more about that.
Yeah, I think there are a couple models that are trying to do it more so that way these days. Yeah, great. Yeah.
Yes, I want to piggyback on that because it's such a great question for every workshop we've had here. I mean, this is really a question, in my opinion, this is a question for the entire conference. Because we all have, I mean, for those of us who are practitioners out in the trenches, we have ends of one. What do we do? It's great to see what all the researchers are doing, and I'm looking forward to the future, and it's very positive. But I also need to go back to my office, and I've got kids waiting for me. What do I do? How do I help those families? And what would be the best resources? I think it would be really helpful if at some point in time that every single person who presented at this conference would send out an email to everybody who participated, 2 places to go online to help bridge that gap. Just to help bridge that gap. You can't do what we're in the middle of clinical trials doing now, but this is what's available here, and this is a great way to start making some of these adaptations or to start using what we already know. I think that would be enormously helpful.
Okay.
So this question was one of the best questions I've heard this whole conference.
Yeah. Yep, I'll commit to that, and I'll try to send out 2 resources, but your point's not taken lightly, and there are some models that are trying to do exactly what we're talking about, make it more individualized so it's more accessible to clinicians, so you don't have to wait 15 years for the next adaptation to come out. Yeah. Great. Okay, thank you.